Hello everyone, welcome to the live interviews we are conducting as part of the India Live 2024. I have with me here Dr. Rasha Al-Lamee. She's a renowned interventional cardiologist from the United Kingdom. She has been the principal investigator of the Orbita trials, which have been a landmark trial if we talk about chronic coronary syndrome. So welcome Dr. Rasha, welcome to India and welcome to India Live 2024.
Thank you so much for the invitation. We're having a fantastic time.
Great. So let's begin our discussion by talking about chronic coronary syndromes. So there has been a lot of talk about what is the hard endpoints of revascularization in chronic coronary syndromes, because whenever people talk about endpoints, everyone says there is no improvement in hard endpoints. So Orbita trials were the ones which really made a difference. So can you just give some insight on that?
Yeah, so I think you're quite right. In the world of chronic coronary syndrome or stable coronary artery disease, a few decades ago, I think we hoped that revascularization would do much more for our patients. We thought that it would reduce the event rate in terms of myocardial infarction, it would improve mortality. Right. We almost saw stents as a preventative measure. You have some disease, if I put in the stent, it's unlikely to get worse. But actually, with the advent of many trials, Courage, Ischemia and others, we've seen that in the stable space, revascularization with stenting doesn't seem to improve those hard outcomes. But I would argue that for our patients, actually most of them, what they really care about is their symptoms, their quality of life, and the fact that they have angina and that limits their quality of life is really important to them. And maybe now we need to come to a place where we decide that in this scenario, the role of angioplasty is much like a hip replacement for osteoarthritis. It will improve symptoms potentially, it might improve their quality of life if we select the right patients for the procedure, but it won't necessarily change their life expectancy.
True. So in your routine clinical practice, do you do an outpatient ischemia testing for your stable coronary artery disease patients?
Yeah, so in the UK, the practice has been for a long time around anatomy. Right. So we use coronary CT as our rule-out test. Right. And for most patients who come to our chest pain clinics, that would be the first test of choice. Okay. If I see that that's normal, then I don't proceed further. Mm-hmm. If, however, that I see disease on a coronary CT, then I might think about the next steps. And I think what's most important is thinking about the symptoms of the patient. Mm-hmm. So it is important to remember that if we want revascularization to improve symptoms, then the patients need to be symptomatic to begin with.
Right. Because there are a lot of patients in our routine clinical practices who don't have much of symptoms, but they throw up a decent amount of ischemia on ischemia testing. So then comes the thing with the ischemia trial, which showed that even with moderate to severe ischemia, there's not much of a difference. Then comes the dilemma that what do you do with these patients?
Yeah, so I think that silent ischemia space is really difficult. Right. We have to remember that there's subsets of patients that weren't studied in the ischemia trial. Correct. Left main disease patients weren't there. I think it's important to remember that maybe in the very severe three-vessel disease space, like you often see over here in India, I'm not sure if as many of those patients were recruited into the trials as we'd have liked. But overall, I think from the results of ischemia, it seems that revascularization doesn't really improve outcomes. There's a signal that it might reduce spontaneous MI, and I think when we see the long-term follow-up from ischemia, we may have more information about that, but it certainly doesn't seem to improve death.
Yes, because the long-term outcomes of ischemia, because there was a crossing of both the curves. Yeah. And I think as more and more data about ischemia comes around, maybe we'll get to know what actually happens with both the curves and where do we land up finally.
Yeah, I think it's important to remember that when you have a median follow-up of a trial of 5 years, that may be important for your 80-year-old patient, but for your 50-year-old patient, you probably want long-term follow-up that's a lot longer than that.
You need to have a lifetime management of CAD, as we always talk about in valve diseases. So when we talk about optimal medical therapy, how aggressive are you in statin control and what do you do all around it?
Yeah, so I have to say, for me, optimal medical therapy goes into two phases. Right. One is risk reduction and disease prevention or disease modification. And then the other aspect is anti-anginal therapy. On the risk reduction side, I'm very aggressive. I think that patients need as much lipid lowering as possible, and I tell them the lower the better. I'm incredibly aggressive with hypertension control, diabetes control, and actually antiplatelet therapy where necessary when they have significant coronary artery disease. And that side of things, I tell my patients, is not going to change. Right. Regardless of what we do in terms of revascularization, we have to control their risk. Yeah. I think it's also really important to tell them that the stent or the bypass doesn't fix the disease.
Correct.
The chance of them coming back with more events is still there if they don't stop their smoking or control their diabetes or their hypertension. So that's a really aggressive aspect.
There's a very important message which needs to be conveyed to the patients across the table, because a lot of patients have that first question that if I put in a stent, if I go through a CABG, will my number of medications come down? And even because a lot of these patients are commonly followed up by our GPs who are not very clear about how aggressive they should be in medically treating. So there is a lot of discord in what we see in the routine clinical practices, what OMT is, and in the trials, the OMT, which they were specifically instituted with achieving an LDL as low as possible.
I think that's absolutely right. And I think the other thing we're very bad at doing in clinical practice, and maybe a little better in the trials, is checking the adherence of our patients to these medications. So they may have a very long prescribed list, and they may take 30% of that risk every day, of that list every day. So I think that's a real important aspect. I see with our primary care physicians that, again, there's a lot of education needed. Somehow they also still believe that the stent fixes the disease, and you have to teach them that the disease is still there. That all the stent has done is pause or improve symptoms for a brief period of time. It's done nothing for the actual lifetime course of that disease.
In our Asian subcontinent, there's the incidence of diabetes and hypertension is so much that many a times people just don't pay attention to the diabetes and hypertension control, and they just keep on wondering about what do I do with my coronary artery disease when that diabetes remains uncontrolled and keeps on increasing their coronary artery disease.
And as we know, with each event that they come back, and every time we revascularize them, the risk is higher, and the chance of us actually improving things goes down. And so it is important to teach them about disease modification.
That's very true. So if from you I take a single take-home message about chronic coronary syndrome revascularization, what would that be?
Yeah, so I mean, I think what we have now from Orbiter 1 and Orbiter 2 is guidelines really on how we deal with symptoms. And what we've learned from Orbiter 1 is that on the symptom side, on the anti-anginal therapy side, if you give patients multiple anti-anginal medications and then reserve angioplasty at a later stage for those patients who are still symptomatic, you probably select a group of patients who have the least to gain. Maybe some of those patients have non-cardiac chest pain. With Orbiter 2, what we found this year was that actually, if you think about anti-anginal as angioplasty as an anti-anginal procedure up front, it's actually most likely to have its gain. But with all of that, of course, comes risk reduction. So for me, a patient with stable coronary disease needs aggressive risk reduction with medications, and then they need a discussion about two possible pathways. An anti-anginal medication pathway, which is very valid in a lot of patients, and for many of them improves their symptoms, but they'll be on tablets forever. And then another pathway where you give them the risk reduction medication, and for their symptoms, you consider angioplasty procedure up front. And there is a significant proportion of patients for whom that will make them free of symptoms, and hopefully, with the right risk reduction medication, stop them from repeatedly coming back.
True. Thank you, Dr. Rasha. I think the message is very clear that medical therapy, no matter what we do to the patients, optimal medical therapy needs to be actually optimal. We need to be very aggressive in disease control, very aggressive in treating their risks and their comorbidities. Otherwise, we may not gain much.
Exactly.
Okay. Thank you so much for joining us.
Thank you again.
In the live interviews, and we hope to see you again soon. Thank you so much.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.